Can you help me welcome to the stage Mr. Chris Cartwright? Thank you.
Nice to be introduced by somebody I know really well and I have a lot of respect for, so thank you for that. Okay, so it's predominantly about QuickSin today. It's not entirely, but it's a topic which I think is really important to have a look at and discuss. And I went for the largest title I could possibly think of, so the title was a little bit ridiculous. But it's really just to say that this is a test that we should all be performing routinely. We should be doing it in different ways. And there is visual tools that you can use to try and get the information across to the patient and the client to understand what's going on. But my starting point is really the fact that if we consider the industry and probably the people in this room, we could probably divide you into two, in as much as some individuals may just be doing a pure-tone audiogram and a click and fit, and you may be doing a very successful business, you provide a really good service, but you might be considering, what more should I be doing? And I'm hoping this talk is going to try and guide you in the right way. So it's really what is going to be beneficial to your practice and your patient. In addition to that, there are probably people in the room who already routinely do relay measurements and QuickSin, and your patient journey might be even longer. But I'm not absolutely convinced that people utilize all the elements of QuickSin that you could be using. So just starting off to begin with, just to say that pure-tone audiometry is really just telling you audibility. It's just giving you the threshold of hearing across the speech frequencies. It's not really telling us how well people can process speech, and particularly process speech in a very noisy situation. There are some average data out there from Mead Killian back from 2017, where he looked at average hearing losses between 500 and 2,000 at different levels of hearing loss, and looked what their requirement was for speech being louder than noise. So average data is already there, but and it is important to consider that if we can even make a slight improvement, even a 1 dB SNR improvement can equate to roughly between about 10, sometimes quoted as being up to 15% improvement in speech intelligibility. But average data on its own is really often not enough. And what you can see on the screen right now is a bit like an audiogram, so having the level going further and further down, and then across the top, QuickSin results in terms of speech to noise ratio. And if you are having a very low score, that's great, and your chances are you're going to cope very well with hearing aids. But those people with a very high requirement, where the SNR result is getting worse and worse, these individuals are really going to struggle. And if we look in blue at mild to moderate loss, even around that 30 to 40 dB level, we see quite a bit of variation. But if we look lower down to about 60 to 70 dB kind of area, then actually the variability we see is huge. And because of that, we really should be taking the time to actually test individuals and find out exactly what their requirement is. And the main point on this particular study as well is that the people who are struggling the most are not always the ones at the bottom of the audiogram. And let's face it, how many of you have been faced with an individual with a dead flat 60 dB loss, and your first reaction is, oh, this ought to be really straightforward, and they turn out to be an absolute real challenge to try and sort them out? Probably because most of those are probably neural problems as opposed to a problem in the cochlea. And when people have a very high requirement, like a plus 25 dB hearing to noise ratio requirement, then there's not a hearing aid on the planet that can provide that. So we need to know, what are we working with? What is the requirement for the individual? So for those of you who are not really that familiar with QuickSin, just a quick recap of what the actual test is. So this can be performed in different ways, but I'm going to start with just thinking about using headphones and insert. And if your hearing loss is 45 dB or better, then you simply play the sentences at a level of 70 dB. If a hearing loss is 45 dB or worse, you simply turn up the volume until the client says it's loud, but it's okay. So the volume is not so strictly important, and what they have to do is just repeat a sentence. And each sentence will get progressively harder and harder. So there's background noise, speech babble behind the voices, and it progressively gets harder and harder. And we try and score them on keywords. So there are 5 keywords per sentence. So it starts off really easy with the speech 25 dB above the noise, and each sentence gets harder and harder in 5 dB SNR steps. And then the result is displayed. If it's between 0 to 3, then it's normal or near normal. 3 to 7, it's mild. 7 to 15, moderate. Over 15 is severe. And the result is compared to normal. So if we had somebody with normal hearing undertaking QuickSin, in order for them to get 50% of the keywords correct, then they would require a plus 2 dB speech-to-noise ratio. So if we do a hearing test, or a QuickSin test on this individual, and let's say as an example, they score 8 dB SNR, then compared to normal, 8 minus 2, it's a 6 dB SNR loss. So that's how the information is provided to us. Now my first point is really immediately is about those individuals who come back into clinic to see us, complaining that they don't think they're hearing quite as well as they were before. And more often than not, we just do a straightforward pure tone audiogram and turn around to them and say, don't worry about it, your hearing's no different from what it was a couple of years ago. And yet in reality, audibility may be exactly the same, but their ability to process sounds and speech might be more and more difficult for them. So really we should be performing QuickSin even on these individuals who are coming back to clinic, and particularly when you consider that something has triggered them to make that journey and come back and see you. So we really should be investigating these individuals a little bit more. So QuickSin, we can use it and perform it for a number of different things. So to begin with, it's given us an indication of what the real world is like, what's likely to happen for them when they're out and about in their daily lives. It also gives us an indication of what their level of technology needs to be. So we're provided with information about the expected improvement with directional microphones. And just be aware that even people with normal thresholds who are struggling in noise, some professionals are providing hearing aids to them. Now that's a little bit controversial, and some of you may not agree with it, but the concept is that by providing some directionality, they may then cope again in more challenging situations. When we have a more mild speech-to-noise ratio loss, then with directional microphones, they may well cope as well as somebody with normal hearing. If it's at a moderate level, we might need more sophisticated directional microphones, the narrow beaming microphone array type of directional microphones. And if it's 15 dB and above, more severe, then hearing aids alone are probably not going to be good enough. And we should be considering communication partner mics, FM systems, or Roger systems. So let's just kind of fantasize for a moment. Just imagine you go to work on Monday morning and your first 3 patients all have exactly the same audiogram. I know that's unlikely, but let's just imagine that. They all have exactly the same audiogram, and the first lady that comes in, we do a test, and her QuickSin result is pretty good. And we fit her with a device, she's really happy, she's hearing great, socializing really well. The second patient, exactly the same audiogram, but now his QuickSin result is really poor. We fit a hearing aid to him, and he's still struggling. He's still not coping. He's getting increasingly isolated and depressed. And then there's the third individual, who, again, exactly the same audiogram, but he's not doing quite as well with the hearing aid as he expected. And maybe he's not doing quite as well as expected as you thought he would. And if you do QuickSin individually, potentially you may find that one ear is performing really well and the other one is performing very badly. And his overall communication ability then is struggling. The other thing just to be aware of when we consider this asymmetry with QuickSin results, there has been a study in 2023 which is suggesting that QuickSin is more sensitive and specific for finding acoustic neuromas than asymmetry in pure tone audiometry. So arguably we should be performing QuickSin looking for these type of individuals who are not, and we all have them, those individuals are not doing quite as well as we thought. Maybe we should be looking at their processing ability individually. And just staying on acoustic neuromas just for a moment, remember that certainly when I first started in audiology, we were always taught that they're fairly rare, you don't see that many of them. And yet very careful autopsies on elderly people have actually found that the prevalence is probably as high as about 2 in every 10,000. That would suggest there's loads of people out there with acoustic neuromas who are not always coming to clinic and presenting themselves to us, or at least if they are, maybe like this gentleman, the third gentleman that we've just seen, maybe because of his overall communication is struggling and we're not investigating it further, maybe we're not finding these because we're not looking for them. So arguably we should be considering using QuickSin on that basis as well. One other thought is to consider that we generally just split up conductive against sensorineural. And I would argue that actually we should be separating whether the problem is in the cochlea or whether it's more of a neural problem. So there are a number of problems that can cause neural issues. Acoustic neuromas are the ones that we tend to immediately think about, but equally auditory neuropathy. So here the cochlea is functioning reasonably well, but the nerves are not able to transmit the information to the brain particularly well. Multiple sclerosis. This is an autoimmune disease that causes demyelinization of the nerves, and again, we're not getting the information being transmitted along the nerves into the brain. Sudden sensorineural hearing loss, whether that be through viral infections, vascular problems, autoimmune responses, we generally consider that that's happening in the cochlea. Equally, some of these could be affecting the neural system, retrocochlea instead. Trauma, and that might be direct physical trauma to the head, it could be surgical trauma, it could be acoustic trauma. I remember many years ago going to a conference and an ENT surgeon describing a receptionist who picked up the phone and somebody played one of those personal alarms, those really loud blasting sirens down the phone, and it took a hearing. A hearing just dropped to the floor and never recovered, and it was classed as acoustic shock. So potentially that can happen as well. Meningitis, an infection, particularly bacterial meningitis, we know causes inflammation of the nerves, and that can cause neural problems. Then there's neurodegenerative diseases or dementias like Alzheimer's, Lewy bodies, frontotemporal dementias, all making different auditory perceptual changes in the head. And that's another topic really that we should be exploring just a little bit further. Chronic diabetes, we know that there's a huge number of people with diabetes. It's reached the 5 million people mark. And we also know things like obesity is contributing to that. And chronic conditions, chronic diabetes affects the blood vessels and the nerves. And then we have genetic disorders. And very often when we think about syndromes and genetics, we tend to presume it's going to happen to the individual from birth. But some of these are kicking in when somebody's in the 30s or 50s. It may well kick in much later in life. Strokes. A lot of people who have had strokes have problems in processing speech. So that may well be equally a problem. Autoimmune diseases, the immune system attacking its own body, in effect, that can cause problems with the nerves and processing. And then we have ototoxicity. We have to remember that there are 270 or plus 270 odd medications routinely used with elderly people which are classed as ototoxic. Some of which tend to attack the vestibular system more than hearing, and others affect hearing rather than vestibular. But we know that when we speak to our clients and we take a medical history, often they'll have a whole list of different medications. And although the level of ototoxicity and the risk might be known individually for each medication, what nobody knows is the combination of all these things happening together. So I would argue that really and truly we should be dividing up whether it's sensory or whether it's neural, rather than just simply pulling everything together. And there are other tests that we could perform, such as speech audiometry with AB wordless, tone decay, a test of abnormal adaptation of the nerve. These are topics that we could easily cover on another occasion. I haven't got time today. But there are more investigations, arguably, that we should be performing to try and really look for these individuals and help them. But pulling it back to QuickSin, so I've suggested so far that we need an indication of what the requirement is for the individual in the real world. It helps us decide what level of technology, kind of directional microphones, whether they need partner mics, Roger systems, and so on. We should be checking these individuals when they're coming back in, concerned that their hearing has changed. But we can also use QuickSin even further. So first of all, there is an association with dead regions, and there are additional word lists that we can use in QuickSin which can help us decide how we should be programming the hearing aids. And I want to just explain this a little bit further for you. And after this, we will then talk about using it for unaided and aided testing. But just staying on the concept, first of all, that when we think about programming hearing aids, normally we just simply do a test and we try and amplify where the hearing loss is, more often than not in the high frequencies, and we presume we're doing the right thing. And if we look at some of the studies, even way back to about 1998, there were a number of studies showing very clearly if your hearing loss is greater than 55 dB at 4K, you may not get any benefit from having amplification in those higher frequencies. So the study which is often quoted is this one by Hogan and Turner, where they looked at different levels of hearing loss against what they classed as efficiency. And an efficiency of 1 meant the patient got benefit, an efficiency of 0 meant they got no benefit, and sometimes some individuals were making things worse rather than better. So by just doing what we normally do doesn't always work. And there are certain red flags that we could consider for possible dead regions. So immediately thinking about really nasty steep slopes, reverse slopes, cookie bites. I had a gentleman email me quite recently, and he's been wearing hearing aids for a while from somewhere else. I can't remember where he was being fitted. But he described everything as sounding scratchy, everything. And I wrote back to him saying, I'm fairly clear in my mind what this is. I need to do some further investigation on you. And unfortunately, he emailed back to say, well, I found another audiologist in the meantime, and they're going to fit me with a different hearing aid. And I'm sat there thinking, without further investigation, you're going to go through exactly the same journey that you did before, and you're probably going to end up in exactly the same place as you were before. We need to be investigating these people more. On top of that, probably anybody who's not doing quite as well with their speech understanding as the audiogram would suggest, then maybe we should be investigating these people more. So we should be looking for dead regions. This is where the inner hair cells are no longer functioning. And just staying on this topic just a little bit further, we can sometimes consider that when we're doing even pure tone audiometry, dead regions are going to create a problem for it. Our result is going to lie to us. So imagine that green area that you can see on the screen there. Imagine you're testing at 2,000 hertz, and you turn it up, you get no response. You turn it up a bit more, still no response. You keep turning it up louder and louder until eventually the patient responds. But in reality, what's really happening is that energy is spreading across the basilar membrane until there comes a point where inner hair cells elsewhere respond. And we take that as our threshold, and in actual fact, in reality, it's off-frequency listening. We're recording completely the wrong result and programming a hearing aid based upon it. The same thing applies when we And just to say that sometimes these individuals, when you're doing pure tone audiometry, will just say it doesn't sound like a tone anymore. It sounds distorted. So sometimes that's an indication immediately when you're testing. So everything's sounding a bit distorted. But we have to consider that if we don't take dead regions into account, when we program the hearing aid, we're probably giving the patient a disservice. So to begin with, if we try and amplify in this dead area, there's nothing there to really respond and effectively process the sound. There's nothing there. It will distort the sound quality. Everything will sound distorted to them, partly because we're getting inner hair cells elsewhere responding. So the sound quality and the distortion created is going to be very obvious to the individual. There's certainly, if the sound reaching the brain is distorted and incomplete, then the individual is going to have to work a lot harder. There's more listening effort and more cognitive load to try and make sense of the information which is coming through to the brain. There's a possibility of decreased speech understanding because we're getting rubbish coming from the dead region and we're getting distortion coming from elsewhere. And there's a very real risk of what's called super recruitment. So here we've suddenly got excessive amplified sound reaching an area which may still be quite healthy. And therefore the individual all of a sudden is being blasted out with sound which is uncomfortable. They'll ask you to turn it down, and then you're probably not optimizing the speech that they need. So we do need to consider dead regions, and particularly when you consider the studies like the one by Susan Scully would suggest when we think about ski slopes, probably about 90% of the patients walking through the door with a ski slope probably have a dead region. When we look at more straightforward losses, moderate to severe, possibly a third of them. It can even happen even if the hearing loss is dead flat. But if we look at the work by Brian Moore, then if we look at 4 kilohertz, if the hearing loss is around 60 to 65 dB, you think you're looking at probably about a quarter of your patients have probably got a dead region. Now you could argue, okay, 3/4 of them haven't, in which case what I normally do is probably doing the right thing. But a quarter of your patients, potentially, you might be making worse rather than better. And when we get down to the level of 75 dB, it's nearly 60%. And when we get to the level of 85 dB, 3/4 of your patients, potentially, you're making things worse rather than better. So we do need to take this into account, and arguably, again, we should be doing more testing. And arguably, we should be doing 10 testing. So just a reminder about this, so let's presume that we've done our normal hearing test. The 10 tests can be performed between 500 and 4K. In this example, we'll be looking below 55 dB, so we'd probably be testing 2, 3, and 4 kilohertz. And first of all, we re-established the threshold in 2 dB steps. So originally, at 4K it was 70, we now find it's 72. And we'll be playing masking noise, the 10 masking noise, in the same ear. So we have a little quiet tone, and we have a louder masking sound in the same ear. And it's generally about 10 dB above threshold. And it's not like your normal masking. You're not going up and plateau masking. This is a set amount of masking that then the patient then has to ignore and concentrate on the tone. So let's do an example. So with this individual, let's presume we've already done 2 and 3 kilohertz and it's not met the criteria. And we come to do 4 kilohertz, and the audiogram we did originally showed a loss of 70 dB. We have to retest in 2 dB steps, and we find that the threshold now is 72. We then use that as our basis to know how much masking noise to apply in the same ear, which is 10 dB above, so the masking noise is now at 82. And then we find the threshold again, and what we find with this masking noise, we now have a threshold of 96. Now, if I'm losing anybody, you're welcome to the slides, by the way, if you can't take the photos quickly enough. But just to say that the end result has to meet 2 criteria. So first of all, your new threshold has to be at least 10 dB louder than the original. So we originally found the 2 dB step size as being 72. When we play the masking noise in the same ear, it's now 96. So we've met that criteria. It's more than 10 dB above. It also has to be 10 dB above the masking noise. So the masking noise is being put into the ear at 82. Our result is 96, so it meets that criteria as well. So it has to meet both criteria to confirm a dead region. So in this individual, 2 and 3 kilohertz were still considered to be healthy-ish, maybe a little bit sick, but not completely dead. It's at 4 kilohertz we find that it's dead. Now, having found that information, we need to consider how do we program the hearing aid. And we have to consider that if we amplify in the dead region, we're going to make things worse. But there is evidence to suggest that we can go up to about 70% within that dead region. So if you were finding a dead region started at 1,000 hertz, you could happily amplify up to 1,700 hertz. But everything beyond that, we should be taking away. So we're provided with a formula, and the formulas are different depending if you're doing a reverse slope or high frequency loss. If it's reverse slope, it's 0.57 times the head frequency. What we're normally dealing with is high frequency, and the formula is 1.7 times the head frequency. So in this particular example, 2 and 3 kilohertz didn't meet the criteria. 4 kilohertz we decided was dead. So we consider 3 kilohertz as being the start, the edge of the dead region. So we use our formula, 3 kilohertz times 1.7. It means that we can amplify up to 5,100, but everything beyond that we should take away. So you would then go into your manufacturer's software, and you would go to the gain handles, and you'd remove everything, in this example, above 5,000 hertz. If you're using some form of frequency lowering, so in this example we've got Phonak with Sound Recover, and its pre-calculation was way up here. But we don't want to put that frequency lowered information into the dead region. So instead what we need to do is ignore the pre-calculation and move it further towards audibility, so we're avoiding above that 5 kilohertz. But let's face it, how many people do 10 testing? Whether you look in the private sector or you look in the NHS, generally speaking, no one's doing it. Arguably we should be, but generally no one is. So I want to bring you back to QuickSin, because this can guide you as to what perhaps you should be doing. So first of all, there is an association between QuickSin and dead regions. So this was a study where they were looking at the SNR loss and comparing it to people with confirmed dead regions in the low frequencies, mid frequencies and high frequencies. And what we see is that when we get a really good result where they're near normal, nobody had any dead regions. When we had a mild SNR loss, 1 in 32 people had it. When we go to moderate, 10 out of 44, and when we had these more severe SNR losses, 11 out of 15. So there's definitely a clear association between the results of QuickSin and dead regions. Now, one of the things that people don't seem to be aware of is that within QuickSin, you have a choice of what word list that you use. So you've got your standard word list, but you also have 2 other types. You have a high frequency emphasis, and you have low pass word lists. So with the high frequency emphasis, you are boosting up the high frequencies by as much as 30 dB from 3 kilohertz and above. With the low pass version of the word list, you're removing everything from 2 kilohertz. So simply, arguably, if you're not doing 10 testing, you could do QuickSin with high frequency emphasis and low pass, and if your patient is doing better when you take everything away in the high frequencies, that's how you're going to have to program the hearing aid. In which case you would then eyeball the audiogram, and you'd have a pretty much a reasonable guess to consider that if the hearing loss is below 60 dB, potentially that's where your dead region is beginning. So I would argue that we need to be considering using QuickSin as a way of knowing how we should be best programming the hearing aids to avoid going into dead regions and making things worse. There is another opportunity for us though, and the other opportunity is something that people sometimes use, and that's just simply showing benefit of a hearing aid unaided versus aided. And this is not in order to tweak the response of the hearing aid at all. That should be done at the time you do relay measurements. This is really all about demonstrating true benefit of the hearing aids. But most people that do unaided versus aided, so your patient sat there in front of a speaker and you're performing QuickSin unaided, and then you use your demonstration aids and you do it aided. But most people who do this only look at the end result. They just simply take the end result of unaided, the final result with aided, and just say, hey, look, you're so much better. But arguably, we could do that in a slightly better way. So first of all, just to say the level that we use when this was first suggested was that we should be playing the stimulus at a level of about 50 to 55 dB. So instead of an average conversational level, it's what was classed as a casual conversational level. But the only problem with that is we know that a lot of hearing aid manufacturers will default to their own prescriptions, and the emphasis of manufacturers is all about first fit acceptance. It's all making certain that everything sounds pleasant when we first turn it on, and as a result of that, it could be that we're not really going to be able to demonstrate as well as we could using a 55 dB input. So I would argue still consider your 65 average conversational level. So we have our patient sat there in front of a loudspeaker, unaided to begin with, 65 dB QuickSin word list. But what I'm suggesting to you now is that you need to score them and record it for each and every sentence. So as you go through the QuickSin result, so your first sentence is dead easy. The voice is 25 dB above the noise. And we're trying to score them on how many keywords they get correct. So let's say this is an example, this gentleman gets 4 out of 5 correct on the first sentence. On the next sentence, he's starting to get just a little bit harder. He still scores 4 out of 5. We now have a 15 dB above the noise. He scores 3 out of 5, and so on. So we go through the word list, scoring for each and every sentence. We should always do 2 word lists when we do QuickSin. So we'll do the word list again and score him again on each and every sentence. We can then add these scores together to have an average and times by 10 in order to get a percentage of speech intelligibility. And then we do the same thing again in the aided condition. So you get your demonstration hearing aid out and you do exactly the same thing again. So we now have information of the percentage of speech intelligibility for each signal to noise ratio level for both unaided versus aided. And we can plot that onto a graph, and we can clearly show the difference between unaided versus aided. Now, when you talk to the patient about this, you do have to be careful in the way that you describe it. So when we look at the easiest situation, when it's a 25 dB speech to noise ratio, then the hearing aids really are probably not having to do that much for them. They're probably not getting a huge amount of use from the hearing aid. In the very worst situation, when it's 0, even when you've got normal hearing, the majority of people struggle and really don't score very highly. But what we're actually exposed to in the real world is generally between +5 to +15 dB, particularly +5 to +10 dB. That is what we're all exposed to as individuals in the real world. And there's quite a lot of evidence to support that. So this was a really large study which was conducted for the Environmental Protection Agency, looking at the level of speech and the signal to noise ratio that people were exposed to at a normal conversational distance of about 1 meter. And they found generally we were exposed to between about +5 to +15. In the next study, again, very similar results, and they actually also recorded the fact that there was very few situations where people were exposed to either a very difficult 0 or even worse, it was a very negative speech to noise ratio. And probably the reason for that is that people have adjusted their lifestyles. They're avoiding people they know they can't cope with. They're avoiding situations they know are really challenging. We also know that automatically we all raise our voices. When we're in a noise situation, we automatically raise our voices subconsciously. But if we know somebody's got a hearing problem, we probably raise it even slightly further still. And in addition to that, if you've got a hearing problem, you probably reduce your distance from the speaker. You try and make life as easy as possible. In the next study, again, similar information displayed in a slightly different way. So in a graphical representation, and along the bottom we have situations of being quiet, being outdoors, going shopping, in the kitchen, in the car. And again, they were basically suggesting that what people are exposed to, the majority of the time is probably at least a +5 dB speech-to-noise ratio, and about half the time up to about +9. So we need to think about technology, we need to think about the environment. Certainly we know that people complain about background noise. That's what they really think about generally. But we also have to consider distance. And remember, the voice will drop off 6 dB every time we double the distance. And we forget about reverberation. Echoes and reverberation will kill speech discrimination really quickly. Reverberation, early reflections are great. They add to the direct voice. It increases the volume that we're listening to, and it creates a nice, rich quality to the sound. But it's the late reflections coming in which destroy and blur everything, all the clarity that we need of the speech. And for every 100 milliseconds of reverberation time, we degrade speech intelligibility by about 10 dB. So not surprising when people go to church, go to cathedrals, they're really struggling. And unfortunately, as your hearing loss gets worse, you're more and more affected by reverberation. And one of the things that we sometimes forget about talking about is critical distance, about positioning. But hearing aids are fabulous. There's some wonderful technology, but they need to be in a normal conversational distance to be able to really get the benefit from everything. And if people are further away, they really must either get off the backsides and get closer to who they want to listen to, or they need to be using partner mics and Roger systems. Positioning is really important. We know that in all the features within hearing aids, the main one for us is directional microphones. That is the key for better speech-to-noise ratios. But of course, directional microphones, generally speaking, is assuming the person in front of you and who you're looking at is the person you want to listen to. We're starting to lose information about what's in the environment around us. And of course, if the noise is also coming from the same direction as the person we're speaking to, then the microphones are not able to attenuate the sound out. And in addition to that, one of the problems we have is the occlusion effect. And we have to make a clinical judgment immediately. What do we do? Because if we need an open fitting, if we need a large vent, then that processed sound is all leaking out, and all the noise which is in the environment is going through the vent into the ear, creating a problem for us. So ideally, to get the full benefit of the directional microphones, we need to occlude the ear. And the moment we do, people start complaining about the quality of their own voice. So there are times when we have to make a clinical decision. What do we do? Do we try and give them better directionality? Or probably, do we try and make it sound better for their own voice? Because otherwise they're not going to wear it at all. So it can be a bit of a compromise as to what we provide. The other comment I would make is that technology is improving. We all see AI and deep neural networks being included, and these promise to try and get much better speech-to-noise ratios. And you can imagine it's probably not going to be in the too far distant future where we'll probably have a husband and wife come in and we'll be teaching the system to learn the partner's voice. And it will be looking for that familiar voice in all the rubbish in the environment that the individual's in. And at that stage, we're really starting to provide some decent separation between speech and noise. And the technology is fabulous, it's certainly getting better, but we know what is provided with information from in a lab does not always equate to what happens in the real world. So we don't always get the same level of improvement as you'd expect in the real world. So we shouldn't forget the use of partner mics, Roger systems. They're still extremely important. We must be using those. So my overall message to you is that we need to stop and think about what we're doing, and we need to investigate further. Here's an example from one organisation that had 6 practices, and they tested with QuickSin over 280 patients, and they found half of individuals had an SNR loss of greater than 5, and about 1 in 5 of them, it was greater than 10. And if you consider, and in the example I've given here, let's say the individual needs an 8 dB SNR improvement. If your technology is only providing 2 or 3 or 4 dB improvement, that person is still not going to cope. When they go down the pub, they go to the supermarket, they go to the cafe, they're still not going to cope. So we really do need to try and persuade people to consider I think accessories is the wrong word. These are communication devices, and we should consider a communication package and not just simply hearing devices. And when we're talking this through with individuals, maybe what we need to be considering is how we deliver that information to them. So possibly we've got these 2 individuals completely different, one doing pretty well, one doing absolutely horrendously. Maybe we can utilize something like these visual representations. So with this individual, she had a QuickSin score of 4.5. That's compared to normal. So the requirement in the real world is 2 dB more than that. So she needs a 6.5 dB SNR in order to really cope really well. So this individual, generally when it's quiet, is doing pretty well, but in other situations, she's struggling. And we could provide different levels of technology, and as we go further and further down with better and better technology, the world is opening up more and more for her. But when we start to provide FM, partner mics, Roger systems, the whole world is really opened up for them. If we consider this individual has a really high requirement, unless he's in a really quiet situation and maybe people are speaking up, or maybe the TV is really loud, that's probably the only things he's really understanding. Pretty much every other situation he's not coping in. It's not surprising he's getting lonely and he's getting depressed. And when we start considering adding the technology to this individual, it's still not making a real huge difference. So even with the very best technology, he's no better off than the lady was, completely unaided. And again, it's only when we start providing the Roger and communication partner mics do we start to see real improvement. But maybe that kind of graph is a little bit too much. Maybe an alternative is just something a little bit simpler. So here we've just got QuickSin along the top. The example I'm giving is this individual scored 6 dB SNR loss. It means that in the real world her requirement would be 8 dB. If we just gave her fairly standard technology, they'd still have problems in noise. Give slightly better technology, the world is opening up just a little bit more. Give her the very best technology, probably coping in the majority of situations now, but if they really want to cope in every situation, again, utilizing further technology. So I've almost finished. My final slide is just a quick recap, just to say that there's huge variations, so we should be measuring this. I would argue that we should be doing the test individually to pick out those individuals with potential acoustic neuromas, which we are possibly missing at the moment. That there's an association with dead regions, and even as little as a 65 dB loss, you could be, a quarter of your patients could be having problems. And if we're not doing 10 testing, we should be utilizing these high frequency emphasis and low pass word lists in order to determine how do we program the hearing aid. Do we program it as we normally would, or do we take away some of those high frequencies? And then finally, if we are doing unaided versus aided, scoring each sentence individually, and then we can actually plot and show real benefit of what they could probably expect to have in the real world with a +5 to +10 SNI improvement. And that's it. I hope you found that useful. Thank you for your
Ladies and gentlemen, Mr. Chris Cartwright of the Audiology Academy. Can we give him a massive round of applause? Thank you, Chris.